Okay. All right. So this is the open dialogue with the LFS community. So that's you guys, but it's also us too, and sort of a mix of researchers and people who've presented throughout the conference. We'll go through and we'll reintroduce ourselves in a moment, but what we really envisioned for this session, this was very successful last year and at previous conferences, is really just questions, whatever comes to mind, any type of questions. Do dogs get LFS? I heard in the background. The answer is yes, actually. It's true. There's a paper describing dogs with LFS. Can I ride an elephant? We can talk about it and see. Anything that comes up to your mind. So the mics are going to be open, and just come on up and ask questions. Now, we do have cards for people who are shy. We have about 24 different questions that people have already submitted. So if people don't ask now, we'll turn to the index cards. If we don't get a chance to answer the index cards, we were just discussing with Dr. Lufkin, it might be a good idea to post these online so people who aren't here can also get some answers. So this is your chance for the next hour to really pick our brains or have a discussion as a group. Where do we need to see the field moving and so on? And then at 3:30, Jen and I are going to close the conference. We have a little ceremonial dance that we've planned out. She doesn't know that yet, but we'll figure it out as we go. So the mics are open. Come on up. And while you're doing that, why don't we just sort of reintroduce ourselves? So I'm Josh Schiffman. I'm a pediatric oncologist, work very closely with all of our Li-Fraumeni families, both children and adults, and as you heard, also a researcher. And we'll talk a little bit in the next hour, perhaps, about our circulating tumor DNA study and other things that we're hoping to do.
Louise Strong, MD.
You got a mic.
Oh, I have one. Louise Strong, MD Anderson Cancer Center, and I'm in clinical cancer genetics, but primarily research, and a lot of that research is Li-Fraumeni syndrome.
So I'm Isabel Achatz. I'm a clinical geneticist, and I did my PhD in oncology and molecular biology. I'm presently at AC Camargo Cancer Center, but I receive patients from all around Brazil. And I'm joining the NIH next month, but I'll keep seeing my resident patients in distance.
So I'm Pierre Reynaud. I'm a molecular biologist, and I'm working since over 20 years on mutations in P53. First at the International Agency for Research on Cancer, where I developed the database of mutations on Li-Fraumeni families, but also mutations that occur in a sporadic way in other cancers. And since 2 years, I am professor of cancer biology at the University of Grenoble in France.
Hi, I'm June Peters. I'm the genetic counselor on the National Cancer Institute's Li-Fraumeni study, and a lot of our colleagues are here today. Maybe you've met some of them. But my bigger claim to fame is that I sit down with people with colored stickers and dots and stars, and all of the data that you saw quoted today comes from this process of talking about what supports everybody has in their lives.
Okay. Now, the only rules for the next hour are there are no rules, okay? Nothing is off limits. So any question you want, large or small, ask it. Here's your chance.
Hi, my name is Kathy Higgins. I'm from Athens, Pennsylvania. We're a Li-Fraumeni family. We lost 2 daughters to Li-Fraumeni, one in 2003 and one in 2014. I feel very strongly that I want to have a voice. I want to raise awareness for this disease somehow. For the past, will be my 3rd year in July, I've been doing a fundraiser, raising awareness for Li-Fraumeni and raising as much money as I can. I don't feel in my small community I have a big enough voice. So my goal of coming here to this week was twofold. One, to learn more about the disease. We learned we had it back in 2004 after our second daughter had cancer. and to find out what I can do as an individual to honor my two daughters that passed from this disease and try and find a way to have a voice and try and help another family around the world that may be suffering from this and doesn't know it. So I'm just trying to find out if there's anybody here that can network with me and tell me what I can do as an individual to help raise awareness for this disease. So.
Your work is being amazing already. I think this is one of the most important things we have at present. The population doesn't know well enough Li-Fraumeni syndrome. The medical doctors, all the health community know very little. So our work as medical doctors involved in Li-Fraumeni have been trying to educate medical professionals. And today at lunch, we're sitting with the Li-Fraumeni Association and with the Brazilian members who are here today trying to think how we can get the population awareness of the disease. Of course, in our country it's different because we have a very high onset, but it's not different here. We need to get to schools, we need to get to communities, we have to go to colleges, we have to find every single opportunity to talk about the disease, and that's how we're going to get awareness. If someone from the media calls you, you have to answer, you have to be clear, you have to find flags within your own Li-Fraumeni community who can speak and say the importance of diagnosing, the importance of knowing who are the carriers and taking action into it. So your work is wonderful, and try to find as many people as you know to become, how do you say, speakers of Li-Fraumeni syndrome as well. There's not a recipe of how to do it, but your action is already very important.
Well, and I think you have a large number of people who are already here, and especially the leadership here in the LFS Association and such to gather some together and to put together some ideas. Certainly there are lots of opportunities in various communities, whether it's a school project or whatever, to raise money and to sort of get a word out. But when you're working with school-age kids, it means you can communicate with families who have children who theoretically could be at risk or could be people who would want to be part of this momentum.
Who remembers a couple of years ago, it was pretty hard to walk through an airport without seeing the signs for infectious diseases in kids. Do you guys remember? I see some nodding heads. There was a really big campaign that, yeah, immunodeficiency, primary immunodeficiency. One could make the argument that primary immunodeficiencies are more rare than Li-Fraumeni syndrome, especially if Li-Fraumeni syndrome is 1 in 1,000. But we don't know. We have certainly 1 in 5,000. I think it's worth discussing a public awareness campaign. But how can we do that? How can you honor your daughters? Well, if we raise money, and that money can go into a fund to help public awareness, right? I mean, I can imagine the sign right now. You walk through, take a family history, right? I mean, that's the first step. And so I think making sure, and I hope what people saw, the arc of the conference the past few days was, you know, if we can identify people early, we can start doing surveillance and we can save lives, right? And now there may even be new treatments on the horizon. So I think awareness is the first step.
One thing that I've seen other families do as well is work closely with if there's a medical school or a nursing school or some other sort of health-oriented advanced education center in your community, that sometimes having family members going, I can tell you as a medical student, having patients or family members come and actually talk to your class about their whatever the illness was makes a huge difference. I have a colleague who does something similar on a different disorder at a university near the NIH, and the medical students are always just so profoundly grateful, and they never ever forget that case. So if we talk about educating medical professionals, that's really a great way to start, and it's something that families can do without actually raising a lot of money. You can talk to your docs and say, you know, how can we help with education in that way as well?
I would like to broaden the lens a little bit too. There's an umbrella organization called the Genetic Alliance that has been in existence for a number of decades now, and they represent well over, I think, 1,000 different rare disease organizations. And so there is the bigger picture here of the numbers that I think one of the early talks, cumulatively, this syndrome is a companion to many other syndromes, and you can have a bigger voice on policy, on government funding. How do you think the you know, in the Affordable Care Act, how do we think we got covered for existing conditions? I think it was advocacy by all of the groups, and so there are bigger alliances, I think, that we can make and have an impression on another level as well.
What I would like to add to many things you have already said is that the disease, the syndrome, doesn't make any sense if we look one person at a time. It's even very difficult to understanding if we look one family group at a time. It starts only to make sense when we look at it as a large group, as a collectivity. And if we start to understand what links and what is similar to these different families, and it is absolutely essential that this work is supported by the active engagement of patients, families, relatives, in actively contributing to research, fundraising, awareness, but also participating, providing information about, I would say, the life trajectories, what experience people are going through life, what disease they have, what difficulties they have, and so on. We still have everything to understand. What we know is probably still the tip of an iceberg. And you have also to keep in mind that here in the US, and also even to a lesser degree, but in Europe too, there has been over the past few years a movement to develop awareness and to start to get organized. But you are at the forefront for the rest of the world. Brazil has moved a lot, but it's the only place in Latin America that has started to structure itself. So there are thousands and thousands of families out there. In India, in Asia, in China in particular, where you can see, and there's 1 billion people in China, we don't have clinicians and scientists from China present at the meeting. Same from India, 1 billion person. In Africa, 1.2 billion today, 2.5 billion in 40 years. They are not there. We don't have a single Li-Fraumeni family identified there, so everything has to be done. And by knowing these Li-Fraumeni families there, we'll probably learn a number of variant things. I mean, different presentation of the disease, things that occur in a different context. All this will tremendously help us. And I think that it's our activity as scientists, but also your engagement as patients will make a difference.
First off, I wanted to thank this panel and the other panel of speakers that have come great distances to meet with us. I think on behalf of the LFS families, we've learned a lot, so thank you. Are any of these studies open to other countries, like Canada? When I was diagnosed in 2014, I made several attempts to contact people down here for the different studies and received no information back.
Well, there are several different studies. It depends what type of study you're discussing. One of the issues becomes IRBs, and if it's America versus not America. But many of the biology studies, and one of the things that LFSA is starting to do is to consolidate. There are ways to get people involved. Now, I mentioned a few times our circulating tumor DNA study. That is going to be open in North America. We hope to include Canada. The eligibility for that will be the patient or family needs to be with a practicing practitioner who can follow up appropriately if we find anything. So that's really one of the limitations to that. But as the studies open up and get larger, they usually start locally and then expand from there. But as researchers, we work really hard to get any family in a study if they're interested, because just like we were saying, every family counts, because we learn so much, especially because, I don't personally believe it's a rare syndrome, but we'll put some air quotes around it, right? As a rare syndrome, as we're learning more, every family, every person counts, and obviously if we can make a difference in someone's life, we want to.
Okay, thank you. So our longitudinal cohort study at the NIH is open for North America. Okay. So we have participants from Canada. We are collecting comprehensive medical history information, questionnaire data, family history information, medical record review. We collect biospecimens from the field without people ever actually coming to the NIH. We do, because we're surrounded by epidemiologists, we do a lot of field work. Okay. So we work very closely with the home physicians. So our study is open in a research perspective to Canada. We're also in the process of, we'll be translating questionnaires into Spanish. I think that's a very kind of underrepresented area in a lot of these studies. And the other thing I'll just add too is that I think for all of us who are doing LFS research is that those of us collecting samples from patients are collaborating with lots and lots of people around the world, really. So I have collaborators all around the world to whom we send samples of DNA or cells or something. So even if there's maybe not a study in a certain country, there may actually be a scientist working on something related to our study.
I'll also say, and I know this is true for Sharon as well, but we welcome families to visit us, right? So we're in Utah, and
Not too far.
well, it depends how you look at it. A whole world away, a universe away, depending. But anyways, but if people want to come for clinical care, that's also an opportunity to enroll them in the research trials at the same time.
Okay, thank you.
I would just like to comment that as I mentioned at the beginning of the meeting, one of the big things will be big data, having enough data for each different mutation or tumor type or whatever the variables that everyone brings to the table. And so every individual's participation is valuable. Our research as well includes people from Canada and anywhere that they want to participate. But all of these or many of these data will be into a database so that all of us investigators, whether here or not here, would have some access to that information to help put together a much bigger picture. I think the much bigger picture will be maybe much easier to create the kind of awareness that we would all like to see. So I would say be sure you get into a study where there's samples and documentation and so forth, and where you'll be followed. And it doesn't mean you have to come as a clinical patient. That's where some of the tricky things come into the mix of the different countries and rules and regulations. But as a participant, as an LFS, you would be very welcome.
Okay, thank you.
I'm sorry for going backwards, but and I apologize for your loss, but I wanted to answer her question. My name is Margie. I have a family of 6. 50% of my family is LFS positive, including my husband, who's had 8 occurrences and is doing well. I have a daughter who had rhabdo at age 3. She turned 16, and today coincidentally marks her 13 years of diagnosis, and she's doing well, and a son who has had no occurrences. But what we have chosen to do is I've teamed up with Children's Nicholas Hospital, Miami, and with our pediatric hematologist oncologist, and I do go see all the Li-Fraumeni families, and I help them and guide them in genetic testing as far as, just raising awareness, educating them. I would hope that we would have a database to have everything under, because that's the tricky part, but we don't. And they really, really, really appreciate it. The families, nobody knows. So you just have to get the word out there, the children, and that's how we have chosen to give back little by little. And it really makes a big difference, and it makes a big difference to them. And maybe if you just start, team up with somebody close to you, local hospital or something, and slowly you'll, if you're okay on, talking to families, and it makes a big difference. Okay. Welcome.
I think that's a great idea, and that's an excellent point. Whenever we get a new diagnosis of Li-Fraumeni syndrome, our genetic counselors who are hiding in the corner know, I always offer to the patients, are you interested in talking to other people with Li-Fraumeni syndrome? Some say no, but others say yes, and they do find comfort in knowing, hey, I'm not the only person going through this. But it'd be fantastic if the LFSA had, just like you're saying, a database where if they get a call from a new diagnosis, oh, you're in Miami, we know who to send you to, who's the local person. Because, yeah, it's great to speak over the phone or Skype, but even better to sort of sit in a coffee shop face to face. So maybe LFSA could work to get that database together of, who are the members, and a little asterisk next to your name if you're willing to speak to a new diagnosis family.
And actually, I was persistent. Somebody did want to speak, and I kept on, and eventually, when the time is right, they call you, and then they're appreciative, and they need the guidance.
I have to speak up for Margie and her family. They're a roadshow in terms of helping educate not only families, but also healthcare providers about LFS. She has come to some of our meetings when we were meeting with each of our departments to try to tell them what we were trying to do about LFS, and she came and gave her story, and it had a tremendous impact. So she can help educate across the board.
Hi, just in the past year or so, we found a mutation in P53 in my family. It's phenylalanine at 338 to serine, which is directly adjacent to the R337H. So I'm wondering what kind of light adjacent mutations might be able to shed on each other.
They're discussing it in a different language first, just to make sure they've got their answers straight.
I would be very interested.
Just to make sure I get the numbers right.
Pardon?
Just to make sure that I fully understand, because I thought that you first talked about 238 and this
338.
Yeah. It really needs to be looked very carefully. But just to give you an insight about this 337H mutation. So 337 is one position in the gene. It encodes for one amino acid, which is an arginine. In the Brazilian patient that carried the 337H, the arginine is replaced by an histidine, and they have this very particular phenotype. There is another mutation that we find in a number of Li-Fraumeni families, where instead of having an histidine replacing the arginine, they have a cysteine replacing the arginine. And these families, they have the classical profile. The single, even the same position in the molecule, the difference in amino acid changes the profile.
Yeah,
so my expectation is that a change at the next amino acid, as is the case in your family, will not be any relationship with the specific profile of the Brazilian families. But it needs to be looked at for what it is. I mean, we will have to go in detail and look at the profile and try to see whether it makes sense compared to what we would expect as an effect on the protein.
Okay, thank you.
Just two things, and one is concerning what was brought up about a database. Can we start that today, like a list? Because
Of people who are willing to speak?
yes, because I know where I'm from, Vancouver, Canada,
Yeah.
and every oncologist that I've in contact with, or doctors, everything's so confidential, like they can't give out anybody's name. And I'm so frustrated because we've had a number of experiences I'd love to share and support people, but
Well, I think that's what LFSA can do as an honest broker, right? As a doctor, I can't say, oh, go call, Joe, Mary Ellen, but I could say, talk to the LFSA. They'll give you the names of the people locally who are willing
right,
to speak.
but where can I put my name on? Can we start that list today?
Jen's in the back.
Okay.
So
Good.
I think,
I
this
will
is
be there
this is again, this is something we could have. Oh, we've got right up here. Put your name on a pad and
I'll start the list.
pass it
okay?
around. That'd be great. If you are willing to, speak to a local, write down your name and the city where you live.
Chiquita, you can be next.
I'm
Yeah.
here.
Oh,
Can
Okay,
I respond? Can I respond?
yeah.
I was invited a couple weeks ago by Genome BC to attend our Liberal MLA luncheon. And I made a suggestion there about, we were talking about disclosures and freedom of information. In Canada, we sign off to be organ donors and such. And I said, why don't we have a card that gives information that we sign off that our medical information can be shared within the community.
Right.
So that was something that one of the MLAs, one of our provincial or federal government officials said that they would look into.
Good.
Whether it happens, I don't know, but
So that's a challenging thing, right? Because we're all taught to protect patient
That's right.
confidentiality at all costs. But what I've also done is I've had study participants or patients from clinic say, you can tell anyone you want my name and my email address, and I'm more than happy to talk to them. And I've done that. So
And I've done that too,
and
but
so-
they don't. So
right, but it's a start, and that's where at least it's a starting point. And then with groups like the LFSA, I think that's really where a big difference can be made. I've worked with other groups where they've done a monthly or every other month kind of group Skype chat where they have a moderator and they have an expert in the disease of interest and different topics every month or every other month. And I've had, not in LFS, but in other disorders, a lot of new families come as that first point of contact as well. So that's another way to kind of, again, get more names out there and get more support for people.
I don't think our doctors would have any problem if I gave them an LFS, Li-Fraumeni LFS card and said, here, give these out. And and the actual patients can contact LFS, the association, and get our names from that. They wouldn't have any problem with that. But just saying, give them my name and number.
I mean, you
doesn't
can
happen.
look. What's the first thing someone does when they get a diagnosis of anything? Right? They go to the internet, and so they're going to find LFSA. And if
Yeah.
you put on the website a banner, like, new to LFS, new diagnosis, click here.
Yeah.
All right. I think there are ways that are pretty simple and straightforward that we could try to connect people and do a better job at it. But you had two questions.
Yeah, that was not really my original question. I did go to the trouble of putting my question on a card, so I want to be sure it gets answered.
Yes.
But I'm interested in knowing about chemotherapy because I know the doctor from France last time in Boston, they were doing some studies on certain types of chemotherapy and the effects on mice and which ones at high risk of causing secondary cancers. And hearing that, a particular one for breast cancer that I was being encouraged to do, I decided not to. But now I'm doing gemcitabine, and I've tried to look up information in reference to Li-Fraumeni syndrome, and I haven't found any. So is there a place or a research article that says so far what they know these chemotherapy agents are at higher risk of causing secondary cancers versus these ones? Yeah.
There's not a place you can look it up as a general. Well, I'm gonna put these down so I can wave my hands around. I like to talk with my hands. Yeah. So there's no rule. But what we say to families and patients, the first and most important thing is to treat the cancer in front of you. And many of you have heard this before. Because we don't want you to have to die from a cancer that we're not treating because of a theoretical risk of another cancer later. But there is a risk. So you have to balance that, and you have to balance that with your doctor. Now, sometimes with cancers, there are different treatment options that achieve the same clinical outcome when you look at the studies. And someone had brought this up earlier, and one of the advantages of having a group to really understand is, right now, at this moment in time, we don't believe cancer for cancer, that someone with Li-Fraumeni syndrome with cancer does worse than someone without. So we don't feel like we need to adjust the chemotherapy for a patient with cancer. And there are two sides of the coin where you could say, well, because every cell in someone's body with Li-Fraumeni syndrome has this DNA repair defect, then that means that their cancer has that DNA repair defect and may be more sensitive to chemotherapy, which works by causing DNA damage. But you could also say, because they have that DNA repair defect, the cancer now has even more mutations than someone who didn't have it, and therefore they may be more resistant. So is it more sensitive or more resistant? We don't know of any difference, so right now we say just treat someone with Li-Fraumeni syndrome the exact same way as you would someone without. But that being said, within those categories, are you guys following me so far? Even with the hand waving, okay. So within those categories of, okay, you're gonna treat someone the same as you would with or without Li-Fraumeni syndrome, there are sometimes options of treatment that have the same predicted outcome. Some involve radiation therapy, some don't. Some involve alkylating agents, which interfere with the DNA and work by causing DNA damage, some don't. So when we can avoid treatment that causes DNA damage, so radiation, alkylating agents, we tend to try to avoid it if possible. I just had a conversation on the way to the airport, whatever day it was that I lose track. Whatever day we came here, I had a conversation in the airport. We have a patient who has leukemia, and we had a discussion, an adult patient, should we do transplant or not? With transplant, there's a lot of exposure to radiation. And so we had as the part of the conditioning. So we said, well, would the outcome be just as good as without the transplant? And the hematologist and I agreed, yes, it would. Well, in that case, let's avoid the transplant and save it for later when we need it. So the rule of thumb, and we get these questions all the time as a community, Louise, you get these quite a bit as well. If you can avoid the radiation or if you can avoid the DNA damaging agent, try to. But if you need it, by all means, use it. So I don't know if that's helpful. But the other thing to know, and again, using LFSA as a resource, which I really want to stress, and you know, Dr. Lufkin's here as the medical officer on that, is we are all available for your oncologist to talk to, right? Chances are your oncologist doesn't know a heck of a lot about Li-Fraumeni syndrome, right? And so we are a resource for you and for your oncologist. So if your oncologist says, gee, I'm not sure what to choose, get in touch with Rob. Rob will get in touch with us, and we'll have that conversation and try to decide what is the best, safest treatment. That is also true. That is also true.
On a slightly more positive note, in two other hereditary syndromes that you've probably heard of, BRCA1 and 2, breast and ovarian syndrome, the Lynch syndrome that involves GI cancer, colon, colorectal, endometrial, and a variety of other cancers. Each of those syndromes also involves a predisposition in part due to inability to repair DNA damage. Treatments have evolved some very recently, some over a period of years, that take advantage of that characteristic of those tumor cells. And so the treatments there are somewhat specific to the syndrome because of what the inherited predisposition is. There is certainly ongoing discussion and some experimentation to consider whether the types of treatments that are effective in those syndromes would benefit those with LFS as well. So it's not, I don't know of yet a outgoing clinical trial, but I would imagine it's going to come along soon. I think some of the experimental work is at the mouse level. You've heard a lot about mice this few days. But I think it's very likely that there will be treatments in the not distant future, but in the foreseeable future that are uniquely targeting the vulnerability of the cells that already have a p53 mutation that's inherent. So it's just a heads up.
And just as a straw poll, because this is something we've talked about a lot in the LIFE consortium, just by a show of hands, if you're comfortable playing along, how many people, either you yourself or a family member, have received radiation therapy? Okay, keep your hands up in the air. Okay. Now, how many people or family member who got radiation had a secondary cancer in the radiation field? Okay. So I would say, what's that? Probably about 20%. If yeah. It's or 10%. 10. Yeah. You work with big data more than I do. So 10%. Yeah. So again, 10 so you know, you can put your hands down. So it's very interesting because we are always very, very nervous about radiation therapy, and I'm not saying we shouldn't be, but it's definitely not 100%, right? It's closer, it seems like 10%. But these are the types of studies that we can do together between the LIFE Consortium and LFSA. Let's just play one more game. Bone marrow transplant, that's another one that comes. How many people have had a bone marrow transplant or a family member with a bone marrow transplant? Yeah, see, this one is hard, so we only have 2. Okay, how many people have had, well, I guess it's just both of you, was there secondary cancer from the transplant? No. Secondary cancer causes, but the secondary cancer wasn't from the transplant. But was your hand up? No.
Yeah, all my family have had secondary cancer from the chemotherapy, all developed myelodysplastic syndrome, AML, that's 4.
Yeah. And was that before or after a transplant? Before transplant. What's that? And after the transplant, did they have any problems or? 2
months after transplant.
Uh-huh.
My daughter had 2 transplants. She lived 4.5 years and then she first had myelodysplastic syndrome, then AML.
Uh-huh.
And had another transplant and lived 1.5 years. So I think she.
Yeah, it's hard to say. But these are the questions that we need to answer as a group so we can understand what is safe and what is not.
Okay. Just a quick just kind of anecdote or question. When we've talked about education and educating your peers and that sort of thing, I've talked with other LFS patients, and we've actually come across oncologists and others who are actively against the Toronto Protocol, or who are, you know, they're educated. In fact, in my case, my oncologist, when I presented him initially, here's my lab results, here's my family history, pretty clear-cut clinical LFS case in my case. They were not at all interested in performing any screening. And it was pretty evident sitting in the room that I wasn't going to convince them. How can we, you know, these are your peers, how can we try to convince them?
I'll just say 4 letters.
I know no one in this room would do that sort of thing,
I said
right?
4. So NCCN. Okay,
Yes.
so the NCCN guidelines, and we saw a little snippet of them before. It says in these, and that's the National Comprehensive Cancer Network. Yeah. So you want to talk about that?
Yeah, no, I've been through this several times. And the first question you should ask your oncologist is, how many Li-Fraumeni patients do you have? So the question is, they're not used to treat Li-Fraumeni syndrome. They're always thinking that we're overdoing it. But the first thing you have to think is, I need a doctor that knows what I have in depth. And try to find an oncologist if you need a second opinion. Not a single doctor has the right or is entitled to deny you of a second opinion. So go and talk to someone who really works with Li-Fraumeni syndrome. I've been through a very hard moment in Brazil. One of the most important oncologists of the entire country, very well known, a professor. His niece came to my office, and she presented me a very, very typical Li-Fraumeni syndrome family. And her father had died of 3 cancers. It's the other side of the family. They were not blood related, but very close. And she said, well, we've been struggling with it. We've been diagnosed with Li-Fraumeni, but we never got tested. But let me put you with my uncle on the phone. And this medical oncologist, I was a young clinician, he told me, I am clearly against it, and I forbid my family to get tested. And then when he hung the phone, I said, well, this is his opinion. I respect him very much, but my opinion is you should get tested. They went out and they came back 2 years later with another cancer in the family, and one of them decided to get tested. And we found the R306X mutation, which is the most malignant of all mutations. And we started screening, and within 6 months, his sister got diagnosed with 4 primary tumors, all curable. An astrocytoma grade 2, a chondrosarcoma grade 1, in situ breast cancer, and the 4th one is a leiomyosarcoma. So within 6 months, so her life was clearly spared, and then we started screening the entire family. So stick to your rights and to what you know.
Well, myself personally, I'm a veteran, so I use the Veterans Administration. Unfortunately, they're not as open about second opinions and that sort of thing, but I did participate in Dr. Garber's whole body MRI, found a couple of interesting things, and suddenly I was they were more interested in screening. So thankfully, in my case, it worked out in the end, but I know other LFS patients have had to fire their oncologist and find a new one. You know, you hate to see that, but, you know.
Yeah, one quick comment. As medical director of LFSA, particularly the first couple years in our existence, that was my primary job. I'd get emails from all over the world. And it's such a small community of providers, even in just general oncology. It's pretty easy to find you a good doctor, and we can do that for you, you know, wherever you are, a phone call or two. So, yeah, you have the right to get a better doctor. So.
You know, in thinking about that too, the other thing, so I've had patients actually take the journal articles to their physicians with mixed results, as you would expect. But LFSA is just a wonderful resource for pushing for this now. And also, I think all of the clinicians who were here at this meeting, and even those who couldn't attend, are all happy to help individually as well, in addition to LFSA. And the other thing I was going to add for LFSA, and thinking about ASCO, being American Society of Clinical Oncology meeting, which is happening actually now in Chicago, is if you have all thought about having a booth at one of the at scientific meetings. Next, okay, Rob said yeah, in the future. But because I found also that, so at these large clinical scientific meetings, there are, exhibitor booths, and there's always a set of nonprofit organizations. And I found that those booths are actually a great way to reach out to oncologists who may say, oh, I don't have a Li-Fraumeni syndrome patient. That's so rare. I'm never going to see that. And then they start talking to the person at the booth, and they say, oh, actually, maybe I do. Maybe I have many. And so it's a good way for LFSA to do more education as well.
Hi, I have a couple colleagues in the VA system who are genetic counselors in Salt Lake City by you. Vicki Vane is one, and Ann Medeo is the other, and they have a...
My genetic oncologist is there at Salt Lake City, so
okay.
She works for Vicki, actually.
Oh, so then that's perfect. Okay, so you're connected. Never
Yes.
mind.
Yeah, and my surgical oncologist, I've just moved to San Antonio. My surgical oncologist there, I'm number 4 Li-Fraumeni patient for him, so that makes me feel a bit better as well.
Well, we feel better for you, too.
Yes, thanks.
That's good. I'm glad you found your way to the right place.
Yep. Thank you.
Josh, can I play your game here and just ask a question to the audience in terms of, I'm interested in the perspectives of who gets referred and where they're getting referred from. My observation is I think a lot of patients, pediatricians are more apt to get someone enrolled in a protocol than maybe the adult world. What's the experience in terms of getting your link in through, say, a pediatric service versus the adult world?
So we should do it as a survey question. So raise your hand if your pediatrician referred you.
Yeah.
Okay.
Or if that's the person that's
yeah.
kind of
If your
championing this work.
pediatrician or pediatric provider referred you for your Li-Fraumeni care, raise your hand. Sort of. Yes. No. Or your child's right. A cancer.
Or pediatric oncologist.
All right, let's do it this way. Any pediatric provider, as long as they have the word pediatric in front of their name, pediatric oncologist, pediatric primary care doctor, refer you to genetics for follow-up and further testing and management. Yeah. We don't really know what the denominator is, but that's... Yeah. 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 And who had a child who had to you did not get referred?
I did it on my own.
You did it on your own.
Because I sort of figured it out and I thought that was happening, so nobody referred me to the geneticist. I did it on my own, but the oncologist referred me to another oncologist that had experience with LFS.
Okay. So like telephone. Yeah.
So I guess
and
that's
how
another
many
question in terms of
the
medical genetics versus oncology service, just in terms of where people are getting referred to, because I've worked in both worlds, and I've had a little bit more of an issue in the adult world than the pediatric world in terms of direction, getting people.
Okay. So who gets their care through a medical their Li-Fraumeni diagnosis and or management through oncologist? On any oncologist. Okay. And then same question, but instead of medical or pediatric oncologist, medical geneticist or genetic counselor or genetic clinic.
I guess the
50-50.
initial one is really
Are those
okay.
your questions?
Yeah, thanks. I just was interested.
Okay,
Thanks.
but again, these types of things, right? I mean, there's a list server for LFSA, right? I don't know how many members there are, but I bet we could do survey questions like that to really try to help understand.
Go ahead, Rob.
And there was some wonderful data presented, and we think about the potential options in the future. And yes, we don't have data from the last 10 years, at least coordinated, or 20 years, but the connectivity of the community is just crazy, is the only word I can say. So you put the word out there, and things will get done.
Okay, mine's not really a question, but I want to take a minute and I'd like to recognize our friends from the LFSA Association for all the hard work they've done putting on this conference. And if I call their name, I'd like them to kind of stand or wave. First of all, I'd like to thank Debbie. Is she in the room? I told her to, Debbie. That's you. I told you to stay. Stephanie's already standing over there. Jennifer's in the back. And do we have Rob? Is there Rob here somewhere? Thank you, Rob. And I have a Susan and a Sue. Okay, very good. I know how much work it takes to put on a conference like this, and it's been a fabulous trip for us. But I have to go on just one more moment here. It's also super duper important to me to recognize our Living LFS Facebook support group. They're the place that we go to when we want to vent, when we need to cry, when we need answers. Really, when we want to grieve, they are there for us 24/7. And no offense to the doctors on the podium, but they know a lot more than probably a lot of you do. I mean, if you need any kind of advice, they've had it all, they've done it all, and they've been through it all. And I want to take a minute. It's very important to recognize some of them that are here today. So if you hear your name, please stand. Tricia, is she still here? She left, okay. Deanne, I know you're here. I just saw you. Okay, Deanne. Anne is right here as well. And absolutely the most fabulous person ever, Jennifer Mallory. So, to me, they're like family, and meeting them here and meeting all the other mutants, meeting all of the other mutants has been a dream come true for me. So I just wanted to say thank you to everybody, and thank you to you as well. Thanks.
Hi. I was wondering if you had any research, or if there will be research for families, and I know it's a small group of families that don't have a mutation but a whole deletion, and if there is any research out there, and what are the maybe differences, or are there, I'm just concerned about that small group and where they fall into all of, having LFS, when thinking about how can we help change people with a whole deletion.
Well, yeah. So there's also a question of what counts as a whole deletion. So Dr. Malkin's done a study where if the whole entire P53 gene is gone and then some on either end, there may be some developmental delay issues, but there doesn't seem to be an increased risk for cancer. But if a small part of the P53 gene is deleted, then there is an increased risk. Maybe you have more details.
Yeah. And these mutations, we are actually looking at them and trying to compare them with the other types of mutations and understand whether they have specific characteristics. And until now, we do not have the evidence that the course of the disease or its general trajectory would be strikingly different compared to the, I would say, more conventional inactivating mutations we have.
And the types of mutations in P53 are being studied by a lot of different groups, and it's actually one thing that, in combination with the IARC database, that the LIFE Consortium now has the data on many hundreds of families and individuals and their specific mutation, which will include those partial deletions of P53. So I anticipate in the relatively near future we'll have more of what we call genotype-phenotype correlation studies, so looking at people who have small deletions, specific mutations in specific regions, and even doing much larger, more statistically robust studies to look at the types of cancers in those individuals.
Okay. And just one more question. For families that have, LFS, and they have family members that were not tested positive. I heard, and I hope I'm not quoting the wrong doctor, I think it was Dr. Malcolm said, we should look at the families and see the type of cancers they've had and how many cancers, and that we should not just kind of put them to the side and not focus on them because they could be at risk for cancers. My concern is that some families are being told that, you're off the high risk category because you are not positive, okay? And then they end up having other cancers or more severe cancers because they were taken off the high risk, and where the people in their families who were under surveillance, caught their cancers at an early stage. My question, I guess, is like BRCA1, BRCA2, when they came out with the comprehensive, do you think there is going to be a future comprehensive in testing for LFS for family members who were not positive, but could there be in the future something that, or will they be retested years to come? Could we be missing something? Could there be something that hasn't just grown or hasn't been found yet in their bodies that?
So that's something that, we and a lot of others are working on. So in this context, we're talking about families who meet the family history criteria for LFS, depending how you define that, but who have been tested who do not have a mutation,
What
right?
about if families know a family who has had a mutation?
And the unaffected individuals.
And the unaffected individuals.
So
I'm talking about, because.
Okay, so let me talk first. I'll clarify. That was, yeah.
But they did get a cancer.
Okay, so there's two different things to think about. One is that the first thing I said, which is not your question, but I'm going to continue. So the first thing is families who have LFS, who by those clinical criteria based on family history, who do not have a P53 mutation. That's actually about 75–80% of people have a mutation. That means about 15–20% of those families do not have a mutation if you fit the classic LFS criteria. Those mutation unknown families are a very active area of research for a lot of people, and I think we've been digging really hard and trying to find the gene in those families. That's a different story than what you're asking about, in that if you have a family where there are some members who have a P53 mutation, and then there are other family members who do not have a P53 mutation but who have cancer. In that case, it's most likely not related to the P53 in that family, in that cancer's unfortunately not an uncommon disease, especially as we get older. And so it's very likely that in families who have a mutation, that a mutation negative person could still get a cancer just like anyone else in the general population.
Okay, so we shouldn't be obsessive about our younger family members?
They should be considered if you have a mutation positive family and they're mutation tested negative, proven negative individuals, they should be considered to have the same cancer risk as anyone else in the general population.
Okay, so there's no research or there's no worry that we could be missing something in the testing?
No,
okay.
I don't.
Okay, thank you very much.
Can you ask a question about nutrition?
I actually have a little, pardon my language for a minute, but there's a point, and then I have a question. So, it's a wonderful conference when, I wasn't here yesterday because I was writing a manuscript, but when I get an excited phone call from out in the hallway, and it's my sister going, "Can you score me some of that elephant shit and, give it to my family?"
To be clear, the medicine is not based on elephant shit.
Yeah.
It's elephant P53. I just want to clarify if there was any misunderstanding.
So I'm cracking up because I'm literal and I work in the microbiome, and I'm like, are they doing fecal transplants on elephant dung? So when you're ready to go there, my family's up for it. But my question actually is for Maria. And you know that you had that great slide of the 100-year-old gentleman. And I'm wondering what bottle of alcohol he was holding, because that could have to do with his, you know, telomere is not chopping down. And also you had mentioned that he's a soccer player and that family had a lot of physical activity. And there's some great research about physical activity, of course, and protective, well, you know, you're shaking your head. So if you could expand upon that, I'd appreciate it. Thanks.
Wow, that's a great question because funnily enough, I have 3 R37H patients who are ultra-marathonists, and none of them developed cancers. We still don't know the effects, and they all come with the same questions. Can they take all those supplements, glutamines and whatever? And what I tell them is that they should go to the local market and they will get much better food than they get in those pills. So what they did was to, instead of taking protein bars when they run, they have like dried bananas and all of that. We never could get to a decision whether this is better or if it's worse. And we know that natural food is always the best, so that's what I tell them to do. And regarding that man, probably was alcohol because their family produces alcohol. So, but after that picture, after his 100th birthday, he discovered a gastric cancer, and unfortunately he passed out of the gastric cancer. But at the age of 100, it's amazing. He lived very well his entire life without a cancer. He was a carrier. And the gentleman besides him is a carrier and never developed a cancer. But his daughter, he called me when she decided to get married. She went to prenuptial exams, and she was diagnosed with bilateral breast cancer at that time at the age of 27. So what we see in our patients is if ever you escape cancer, you have a very long and good quality life, and you look very good.
Hi. I'm just wondering if you or anyone else in the room knows of any resources that help to explain LFS to young children, whether it's some kind of a book, or I know there are videos sometimes that exist for types of cancers, but nothing specifically relating to genetic predispositions.
Yeah, the closest I know of for LFS is actually there's been a cartoon made about the elephant research, and that cartoon has a description of P53 in a little animated way, and they call it the night gene, and they talk about people missing copies of the night gene or elephants having extra copies. So that's one visual way, but again, these are things where I think hopefully Jen is taking a list, right, that the LFSA could be really instrumental. I don't know if it's pediatric oriented.
Yeah, I don't know of anything for P53. Do any of the other genetic counseling? There are materials for general sort of genetics and also for perhaps talking to children about an inherited condition in the family. So those kinds of things exist, both websites and booklets. I'll try to find something if you'd like.
Okay, thank you. 2 and 4. Those are more the 4 or 5-year-olds that because she is part of the Toronto protocol, so she's going to regular appointments, and she's starting to be of that age where she knows her friends are not doing that.
So if you type in Center for Elephant Conservation and Cancer, then that cartoon it will take you to a web page, and that cartoon will be on there. Which again, it's not a P53. It's not a Li-Fraumeni cartoon, but it talks about the P53 gene and why it's important and what happens when you don't have it. So it may be a way to start the discussion.
That's great. Thank you.
Wait, I'm gonna do something. So I think when we told our kids, they were maybe 7 and 8, the 2 that were diagnosed, and what I've chosen to do when we go for testing is I make it fun. Whenever we go for testing, and it's been on a need-to-know basis, but the kids are very different. My daughter did a research paper on the rhabdomyosarcoma and then leaped into the Li-Fraumeni without me knowing it. So some kids want to know, and some kids, my son goes, well, what is that called again? Okay, like he just doesn't want to know. So you really have to judge, guide them as far as to see how much information they actually want. I just told them that, you're given, you have to deal with what you're given, and, this is what we have, and we have to get tested, and if we catch things early, it's a good thing. So, and even with my husband, when we go get tested, we get an MRI, we always go to dinner. We just forget about it, put it behind us, and a good friend of mine told me one time when I was really worried about something, she goes, Margie, stop worrying about tomorrow. She goes, because today will have gone by, you won't have enjoyed it. So we do our testing, make it fun, just forget about it, and you wait for the results, and if something comes back, then you deal with it at that time. So, but and I think maybe because we're a little bit of we're in the medical field, they've seen people, they're not afraid of somebody being sick, or, they've seen us helping people all the time, and I think that's helped a lot. But we've just guided them little by little. Never gave them all the information at one time, and they're really little still.
Yeah, it's just, I think it's complicated too, because with the familial syndrome, you see people getting sick, you see parents that are sick, you could see other family members that die, and how do you differentiate a predisposition? How do you explain a predisposition to a small child as opposed to having cancer? I'm looking for the finer, a way to explain the finer points.
Going to different institutions, you'll find that some places have a psychologist there. So if you're living with Dana-Farber, the Children's Hospital, there's a psychologist there that will kind of come up with a plan for you on how to communicate that sort of stuff. Right. And the larger places have more robust programs for that than maybe smaller hospitals do. So maybe reach out to a cancer center or something.
Yeah.
Also, most children's hospitals will have child life, and they often have little storybooks and things they use to explain things which are difficult. So you can ask if there is a child life service there that they can explain. And it doesn't need to be an active diagnosis. Even for screening and all those reasons, child life will be helpful. The other thing is, it's not a perfect example, but the way I have explained sometimes about another disease, like a hemophilia, which is called genes the recipe of making something. And if your recipe is not right, then the product is not exactly right, or the protein is the product, or the food is the product. So if you miss out something in baking a cake, the cake doesn't come out exactly as you want. It's a more simplistic way. Mm-hmm. And I have been thinking, as you asked, how to modify it, and I can't come up with something, but the recipe is passed down somewhat incorrectly. Some ingredient is missing, which is the mutation. So the product or the gene, the protein that is formed is not exactly what it should be. Right. Okay. If it helps.
Okay, thank you, everybody.
The family cake recipe is no good. Did you have a comment in the back? Yeah, child life.
Yeah, I would like to share my experience in that case, because I had to share with my son, who was 8 when I found out he had the positive results, and my daughter was 10 and she was negative. And I actually used a comparison among many other techniques, and I did consult a psychologist that was specialized in genetic counseling. And I did use an analogy about the risk of accidents with a motorcycle, and when people are using a helmet to drive the motorcycle. So I explained to him that, yes, there are many people who drive a motorcycle even with the helmet, and they are still at increased risk than the general population. Compared to a car accident, because there's a lot around the car, like that can get hurt before your body or your head is hit. And there are still other people who don't use a helmet, so I compared that his gene was defective, perhaps like driving the motorcycle without the helmet. And that doesn't mean he can ever drive a motorcycle. That doesn't mean he will always have to live in fear or have, but on the other hand, I can't promise that things will never happen. But that a lot of people who still like and ride a motorcycle, but they still want to enjoy, and whether they use the helmet or not, they still make that choice.
Thank you.
I just wanted to echo what was said before, that I agree, I don't know of any resources out there specific for Li-Fraumeni syndrome and children, but I think the LFSA is a great organization to maybe put that together. And I think, already a couple of parents here have shared strategies they've used with their children. So I think we have a great resource of people to, send in. This is how I talk to my children, and we could, compile that to, create something so that there would be something, and so everyone, doesn't have to reinvent the wheel, when they want to talk to their children. I think that would be great. So.
Great. Rob, did you have a question?
Just a question. I was just curious what your thoughts were in regards to, we've seen some specific mutations correlate with certain specific cancer diagnoses and specific to age. And so, for example, adrenal cancer at a very young age and rhabdomyosarcoma. And, most of the data that we have is before the sort of pre-surveillance period. And just thinking about what your thoughts are in people who have had maybe 1, 2, and 3 cancers, and then are sort of moving into that adolescent period. And this is a tough question, but sort of what the future holds for them, because we're in, thankfully, new territory for many of these people. So.
Well, since she's laughing, she can stand up and say, yeah. There's a lot of future. Mayada has been through 17 primary tumors, and she's there, and she's an example of life. She's amazing. And she's going to prepare herself to go to medical school next year. So I think of course, there's a lot of things in front of you. If ever you're screened and you get diagnosed and you get the surgery on time, there is lots of life in front.
So why don't we have one last question, and then we'll move on.
Oh, I'm the last question?
Well, then I've got a question for all of you.
You do.
So.
Okay, sorry. Okay, so my question is for the genetic counseling world. As I was diagnosed a year ago, and as I've thought about my journey the past year of coming to terms with the diagnosis, I was really, I was thinking about how once we get diagnosed, we're giving the tools of, okay, here's the protocol for your screenings. Is there, or has there been thought about giving like a coping skill, like ways to cope, like a toolkit? So once you're diagnosed, you're given, this is what you should do medically, but this is what you do to come to terms with your diagnosis. Because I feel like I kind of went through different stages of the grief process. And, if you find other people that have gone through it and they kind of help you, but I thought it would have been nice to walk away with, a little handout of try these methods to help you, so that I'm just wondering if that's been considered or.
I guess I'm feeling guilty right now.
No.
No. Because no matter how much we try to do the right thing, it's not always the right thing or at the right time. And, maybe it's a phone call that didn't get back or something else. I think that that's a really important point to, it's almost like a prescription for just like the screening, that this is as important a topic. What are we going to do right now? Okay, you and I talked earlier that I was nervous before coming up here.
Well,
so you coached me that I should breathe. I should breathe. And that was very helpful. And, take it in stages like that. It's a wonderful idea. And, perhaps some of the other counselors, does anybody want to come up to the podium? I happen to work with great docs, and we're sort of a tag team together, and sometimes you have rapport with one more than another, and we trade off those roles a lot. I think taking care of yourself in the moment, naming the grief, recognizing the grief, and how upsetting it may be to get this news is part of things. And in the beginning of cancer genetic counseling, we used to actually have more visits, more conversations in person on a systematic basis, and now we're all about efficiency, and I think we forget that. So I like your ideas, and I think we should work together on that.
Yeah, I guess I was just kind of visualizing, a handout. You get this paper that says, do these screenings, and some people find out their diagnosis, a friend of mine, her doctor called her and said, Google this, Google Li-Fraumeni syndrome. So wouldn't it be great if there's kind of a standardized, look, here's what to expect mentally and emotionally,
I think standardized is the right word. And again, here's where LFSA can play a great role, right? Imagining a website, a banner, newly diagnosed, click here. Right? Enter your name or your location, right? Like you need to find your local Costco. It gives you the zip code of where you need to go. Same thing, put in your zip code. Here are the people in your area that you could talk to who've been willing to, who said you can contact them. And here's the download. Here's the PDF. Here are some pointers about how to cope with a new diagnosis of LFS. And I think this is something that LFSA can do. Yeah. Cancer.org. And again, we can link to resources that are already in existence. Did you were going to say cancer.org. Okay. Great.
I think that the network here and elsewhere it's instrumental, because I have patients that I think that I can relate to in terms of the way that their body language has come back. I mean, I'm way off. I get feedback later that someone is is of course stressed out about it, but not to the extent that I could have possibly imagined. And I think these kind of networks are invaluable.
Yeah. Yeah.
Then, for example, if you had people that wanted to help, and there would be a list for preceptoring or assign them as an angel, and then if somebody's newly diagnosed, if you want to help, they could sign up and you assign that person for guidance. So it's not for everybody.
Right. But to have the option, I think that's fantastic.
That might work within, because they're already familiar with what's going on.
Right. And I think we have to make it so when it may be already, when you type in Li-Fraumeni syndrome, this is the first thing you're going to do, that LFSA is at the very top of the list. But I do... The list is very long. I have the list. Okay. Oh, good. Oh, that's fantastic. Fantastic. Okay. Is that also the list of who's going to take me to the airport? Yeah. No, that's the thing. Okay, so before Jen comes up and we do our closing ceremony dance, what I want to do is ask you a question. I mean, this has been a fantastic, 2.5 days. We have another meeting that's going to be coming up in Toronto in a year or so. What should we do more of? What should we do less of? I've heard different things, but let's just a couple of minutes, if you just want to share, what did you like about this meeting? Politely, what you would like to have seen differently or less of, more of? Yeah.
I was going to say it's a lot to think about, and that maybe even after you get home, I think it's one of those other list items for Jen and for Rob as well.
This is not your only chance to give us feedback, but if anything is on top of your head.
I also have had several discussions about whether a meeting like this, jumping into very detailed science from the first get-go, is the right way to go, or do we need to have different tracks so that we can all meet in the middle, someplace in the middle of the conference? That's always a dilemma that we all face.
I'm really thankful for everybody who's here and all the speakers, and I almost hate to say this, but if the speaker is not, if they're not as fluent in English, enough to be able to talk to us. I mean, there were several speakers that I could not understand at all, and that made it impossible to understand their slides. So I think that you know, for an English-speaking audience, we need speakers that can speak in English.
Right.
That was a disadvantage.
Okay. All right. That's a good point. Any other thoughts? Yes. Oh,
Yes.
there's two up there. Yes, please.
I am newly diagnosed, so I've appreciated this time to kind of get some knowledge under me, other than just looking at my family history, because I knew Li-Fraumeni's in what my family looks like, and it wasn't great. So I love this. I think it would be great. There was only one time that I felt like the speaker forgot that there were family members and people that have this in the crowd. And this is a total call out. I don't know if he's still here, but he said something like there wasn't any studies over 65 because there wasn't that many people. And I just thought, like, what? So I was totally flipping out. But I got to, like, just whisper down to Dr. Strong and just ask her, like, do you have people in your study that are over 65? And she was like, yeah. That's all I needed. So that helped to be able to, you know, to talk to a pioneer in the field and make that big. And then you get up there and say that there's a 100-year-old. I'm like, fine with it. But so yay. But I think just that just remembering that I loved everybody. I did understand everybody. Sometimes your ears just had to get used to like people's accents. I think just that one little, just remember that we're here. You can talk about, sometimes I'm going to turn off because I don't know what you're talking about. I'll pick back up whenever I start figuring it out. But yeah, just remember that we're here.
Can I just interrupt 1 second? Yes, absolutely. I'm not sure if anyone had a chance to already get it. You probably got alerted on your app for those of you that are signed up on the app, but we did post a survey right around lunchtime about the conference. So it's your chance to be able to give feedback and comments about things you want to see, things you want to keep, things you'd like to see changed in the future. So if you haven't had an opportunity to see that survey, you might just want to go and get that survey, because you can give a lot of that feedback there as well, which will be very helpful as you guys plan the next conference in Toronto next year in October. So.
All right, two more comments, and then we'll close up the conference.
I was just going to say that with the amount of research and stuff, some of us that don't quite go into that medical field of biology and all your little, you know, roads that you take off, maybe there's a way you could get a paper that would explain at the end, or that could be provided, that would say, this is kind of a synopsis in layman's terms, what we're speaking about. Yeah, well, in English, but in, you know, in layman's terms. So, you know, I don't have to try and, you know, because I've got a lot of, you know, long names spelled out, trying to, you know, I'm going to go home and look them up. So that was just my thing.
That's actually a great point. Make that mandatory.
I think we can surely do that for next meetings, is that every speaker could have a small graphical presentation of what is the message and what it means.
Clear message. Yeah.
So obviously you guys have kind of a tough job with the audience that you're trying to present to, because one of the great things is, I don't know how often you all get in a room together, but at least seeing you all together and kind of interacting and bouncing ideas off each other has really just been encouraging for me anyway, and how things are working, that you are working together, you know, addressing my concerns about classification and databases and how you're collecting data has been really great. Maybe a little bit less redundancy on some of the slides, like that was one of the comments maybe I would have, but don't hold back on us in terms of presenting detailed data, because a lot of us, this is knowledge, this is understanding, it helps us cope. So thank you.
Great. All right. Well, thanks for all the great. And don't worry, if you did take the time to write down in the card, we will try to answer those and make those available. So, and thank you so much to the panel for. Thank you.